All right. Good afternoon, everyone. My name is Donna Gunkel. I am the Director of Clinical Integration. So I will be your host today for our diabetes webinar. Um, Today we have with us our guest speakers who are Ern Lau, one of our UMACO dietitians, and Jacob Heiser, who is one of our providers from our United Medical Clinic. If you want to go ahead and share your screen, Ern. We do appreciate everyone joining us today. So we will begin. If you want to go ahead and just put it in the presentation mode. So today, like I said, we have guest speakers. I did want to go to the slide to introduce our entire team. So Kemal is away today. He's our chairman of the ACO. We have Dr. Hundal, who is our program director. He's one of the endocrinologists within our network. We also have Caroline Weber, who is again one of our dietitians, and she oversees the diabetes program. And we have Roxana Portlock and Carla Williams, who are two of our licensed social workers. So we do these once a month, and we have guest speakers each month from our endocrinologist, cardiologist, nephrologist, podiatrist, our social workers, as well as our PCPs who talk about a variety of diseases that affect diabetes or where diabetes affects those other diseases. So if we go to the next slide, again, I've already introduced our panelist. So today we will begin. So today we're going to talk about cholesterol in patients with diabetes. So I'm going to turn it over to Jacob, and he's going to walk us through from the PCP perspective how cholesterol affects patients with diabetes. And then we'll have Ern join us in just a few minutes to talk about Mediterranean diets and how that also affects patients who have cholesterol. All right, thank you.
All right, thank you, Donna. Hi, everyone. My name is Jacob Heiser. I'm a physician assistant, and I work at the United Medical Clinic in the Dover office primarily. So I'm just going to talk a little bit about cholesterol in general and its connection in relation to diabetes for our webinar. So just a little picture there, a little bit of illustration there. You can go to the next slide. Just want to talk about what is cholesterol. It's a waxy, naturally occurring substance in the blood. The best way to think of it is fat. And normally we have a bit of a negative connotation when it comes to fat because, of course, we see how that affects things within the body. However, we do need some fat. So cholesterol is something that is actually produced by our liver, and it's used to build cells, make vitamins. It helps create some hormones. So it is a naturally occurring substance within our body that we do need. However, the problem becomes when we have too much of it, and that is usually going to come in the form of excess dietary intake. So when we're looking at cholesterol, is particularly from our side as PCP, we're mainly focused on a few different things here, starting with our two primary types that we look at, which is your LDL and your HDL. And these are referred to, typically, most people hear them as the bad and the good cholesterol. So LDL is your bad cholesterol, and what it does is it transports fat throughout your blood. And if you have too much of it, you will start to deposit that fat into your arteries all throughout your body. What we have on the other side is your HDL, which is your good cholesterol. And what that does is actually takes the fat away from the arteries back to the liver so that it can be recycled, reprocessed, and continued to be used for natural functions. We also have one other thing that we typically keep an eye on, which is our triglycerides. So that's another type of fatty acid chain. And this is typically coming from excess calories. So we intake calories every day to give us energy. If we have too many calories for what our body is needing to expend on a daily basis, that extra will be broken down and converted to triglycerides. And that's how we can get some extra elevation in that. And as I'll talk about a little bit later, that is one thing that is affected with diabetes where we're intaking too many carbs and calories. So go to the next slide here. Just some risk factors for people to be aware of for when it comes to developing high cholesterol. There is, of course, a genetic predisposition here. So people who have mothers, fathers, grandparents, brothers, sisters, anyone in your family, especially a first degree relative who has a history of high cholesterol, heart disease, heart attack, stroke, those are all typically indicative of someone who has a history of high cholesterol. And we encourage those patients to get tested, usually a little bit earlier than what is normally recommended. Of course, an unhealthy high-fat diet, high-calorie diet, sedentary lifestyle, not doing enough exercise activity to burn those calories in fat, being obese, which naturally will come from a high-fat sedentary lifestyle. All those things can, of course, be controlled. Uncontrolled diabetes is something that also is affecting cholesterol. And then, of course, there's a few things that we can't necessarily control, but that we do look for in patients with high cholesterol, such as hypothyroidism, so an underactive thyroid gland, or in general, are men. Men are typically at higher risk of developing complications of high cholesterol and developing high cholesterol. So moving on to our diagnosis criteria. So this is something that we would be doing in the primary care office. We're going to be checking some screening blood work, checking what we call a lipid panel, and it's going to give us all of these numbers here: total cholesterol, LDL, HDL, and our triglycerides. So what we're looking for is what's called hyperlipidemia, and that's defined as any abnormal cholesterol level. So a total cholesterol of over 200, an LDL or bad cholesterol of over 100, triglycerides over 150, or an HDL less than 40 in men, less than 50 in women. So remember, we're trying to keep our overall cholesterol numbers low, but we want our HDL, good cholesterol, to actually be high. So moving on to our treatment guidelines. So if you come into our office, we do a lipid panel, we have some elevations in cholesterol. Well, next we move on to some criteria, which comes to us from the American Heart Association and the American Academy of Cardiology. So anyone aged 20 to 75 with an LDL above 190, we are recommended to start medication right away. Anyone who's 40 to 75 who has known diabetes, we will typically start medication right away. If you are under 40 with diabetes, then we will typically take into account some other risk factors such as high blood pressure, family history of heart disease, smoking. Those kinds of things is what helps drive our decision making, because those are all other risk factors for development of plaque buildup and heart disease. Then if you have a 40 to 75-year-old who does not have diabetes and an LDL between 70 to 189, that's where we again are using our risk factors to take into account whether or not we would want to start medication. So what I have listed here is what's called an intermediate risk score, and we determine that with something called the ASCVD risk calculator. And this is another tool that comes to us from the American Heart Association. Takes into account things such as your age, your sex, your race, what your cholesterol is currently, what your blood pressure is, if you're on medication for high blood pressure, and if you have a smoking history and or a current smoker. So putting all of that information in whenever I get a patient's labs, it will give me a percentage chance of somebody having some sort of cardiovascular related event, such as a heart attack or stroke, over a 10-year period. And what's considered to be intermediate risk is about 7.5% or higher. So usually when I have my discussions with patients about their cholesterol, I'll tell them that I put all this in, I ran their risk, and if they are above 7.5, we make a decision about starting medication. And the important thing to note here is that the reason that we have these guidelines and the reason that we make these determinations is because persistently elevated cholesterol levels will lead to plaque buildup in the blood vessels, which can lead to heart attack, stroke, and peripheral artery disease. So if you have a blockage in a heart blood vessel, that's how you can have a heart attack. If you have a blockage in, say, your carotid artery in your neck, if you can't get blood up to your brain, that's how you can have a stroke. And then we have peripheral artery disease, which is where you get blockages in your extremities, like your arms and more commonly your legs, where you will have pain due to lack of oxygen and blood flow in the vessels of your legs. So we talked a whole lot about when do we treat. This is going to answer how do we treat. So of course, at the end of the day, all of these problems, diabetes, cholesterol, high blood pressure, obesity. We always, always, always are preaching good diet and exercise. So 3 to 5 days a week, 30 minutes per session at minimum, for good cardiovascular exercise has been proven to reduce all of those things: cholesterol, diabetes, high blood pressure. And then I'll let Ern discuss a little bit about some of the dietary changes that can be made. But when it comes to initiating medication, the gold standard therapy for us are what are called the statins. And I'm sure a lot of people have heard of those. Some common examples: atorvastatin, rosuvastatin, simvastatin, pravastatin. Those are your Lipitors and your Crestors. We do have different intensities based on the type of medicine as well as the dosage, and we make that determination kind of, down the line as far as what kind of labs we're looking at. But these are really great medications. They work very well at reducing those cholesterol levels. Now, some people can't tolerate them. They do occasionally have some side effects that we do discuss during our visits. If they cannot, we move on to something like a Zetia or ezetimibe, which is a different class, is designed at targeting cholesterol. Or something that we may switch in or add in addition is like a fenofibrate. And fibrates are good for triglyceride management in particular. For other people who cannot tolerate statins, we have a new class that is starting to hit the market and become a little bit more popular. They are called PCSK9 inhibitors. So these are biweekly injections. And the most common ones right now we have are Repatha and Praluent. So these are some that we're starting to see a little bit in primary care. We're also seeing it used a little bit more with cardiologists who are managing people with resistant high cholesterol, those who can't tolerate the statins. And then if you're wondering some things that maybe you could do on your own before needing medication from us, there are supplements like omega-3 fish oil pills, red yeast rice, niacin. It is a good idea to discuss with your healthcare provider before starting these supplements. But just so you can be aware of some of the potential side effects and how they work. But omega-3s are pretty good for triglycerides that incorporate some healthy fats into your diet. Red yeast rice and niacin, both helpful for cholesterol. And then just moving on, so a little bit more information about cholesterol and its relation to diabetes. You are more likely to have high cholesterol if you are diabetic. Again, as I said, everything tends to go sort of hand in hand for a lot of our patients. An unhealthy lifestyle, including a high-fat, high-carb diet, sedentary lifestyle, low exercise, and an accumulation of excess body fat will typically lead to high blood pressure, high cholesterol, and diabetes. We also will typically see a little bit higher triglycerides in our diabetics, just because, again, due to the increased caloric intake, carbohydrate intake, and it does cause some insulin abnormalities, which makes it a little bit harder to break some of those triglycerides down. Another thing with diabetes that we will typically work with is that our goal LDL is typically going to be lower in diabetics. So usually our goal is to be under that 100 threshold for LDL. That's what's considered normal. If someone has high cholesterol to the point where we put them on medicine, our goal is to get them under 100. However, for our diabetics who have any sort of increased risk of cardiovascular disease, meaning they are over 65, they're a smoker, they have high blood pressure, they have a family history of heart disease, heart attack, stroke, anything like that, then we typically will change the goal to be below 70. And that's why we are usually a little bit more aggressive when it comes to statin therapy and overall management in our diabetics. So once again, mainstay of treatment for all of this is lifestyle modification and risk factor reduction. If you have high blood pressure, we want to get that under control. If you are overweight, we of course would want to help you lose weight. We want to eat right. We want to get regular exercise. If you're a smoker, we encourage you to reduce or completely abstain from smoking. The goal of our clinic as primary care is about preventative medicine. Most people don't know that they have high cholesterol unless they get checked with a blood test. You will not notice that, my cholesterol feels high today. You will not have any symptoms of, discomfort or pain when you have high cholesterol until it gets to a point where you start to have blockages. And that's where we get concerned, where you can have a heart attack, a stroke. You'll have pain in your legs because when you get up and move around and you need more blood, you can't get it because of those blockages, and you will have pain from that. And by that point, you might need a procedure. You might need a stent. You might need something to be done that is a little bit more invasive. And so the goal for us is to reduce these risk factors, keep these levels low, and that is what will keep you living a healthier life for a much longer time period. So feel free, if you have anyone that needs to be seen, we do encourage everyone to come in for yearly physicals at the very least. Would love to get some baseline screening labs and look for these kinds of things. And if anyone has any questions, feel free to reach out to us. So I'm going to turn it over to Ern now, and she's going to discuss a little bit more from the dietitian side about a heart healthy diet and things that can be done to reduce cholesterol from that standpoint.
Thanks, Jacob. My name is Ern. I'm one of the dietitians here at United Medical, and today I will be talking about the Mediterranean diet and heart health. So what is the Mediterranean diet? It is a style of eating that really emphasizes minimally processed plant-based foods. And so we're really emphasizing lots of whole fruits, fresh vegetables, nuts, beans, whole grains, like whole grain pasta, whole grain breads, brown rice. We love olive oil, a little bit of red wine, so in moderation, and of course, smaller amounts of animal products, so fish, eggs, dairy, and meats. It is really inspired by the traditional eating patterns of people who live in countries bordering the Mediterranean Sea, particularly the olive growing cultures of southern Italy and Greece. So this is the Mediterranean diet pyramid. If you can see, it sort of makes food fall into different blocks, and they're of different sizes. So our largest block would be what we recommend for highest intake. So a couple times a day, this should be majority of your calories in a day coming from fruits, vegetables, whole grains, nuts, legumes, seeds, and of course, heart healthy fats from your extra virgin olive oil. And then moving up a category, that will be your moderate intake section, where you're focusing on lean proteins. So fish, seafood, poultry, such as chicken or turkey, eggs, low-fat dairy products like your low-fat milk, cheese, yogurts. And then, of course, up top, you have your lowest intake block, which is going to be about several times a month. These are more processed foods, such as sweets containing your added sugars and red meats that are higher in saturated fats. So why do we recommend the Mediterranean diet? The American Heart Association really recommends this as the gold standard diet in preventing heart disease. With heart disease really being the consistent #1 cause of death in the United States, we really have to start thinking about prevention therapy and managing the risk factors, as Jacob has mentioned, for cardiovascular diseases such as hypertension, high cholesterol, diabetes, and of course, obesity. All of these risk factors are closely intertwined, and any one of them can exacerbate the next, therefore increasing the overall risk for cardiovascular disease or heart disease. For example, if someone is obese, that tends to lead to insulin resistance, which then places you at a higher risk for high blood sugars. High blood sugars can then cause damage to the inner lining of your blood vessels, causing them to be a lot more susceptible to cholesterol depositing. And with cholesterol depositing and that plaque depositing, the blood vessel is now narrower, increasing your blood pressure. And so now we have all of the risk factors for heart disease. And the Mediterranean diet is also what the USDA's most recent dietary guidelines really support. So the American Heart Association's actual recommendations are very close to what the Mediterranean diet suggests. Of course, balancing your caloric intake overall and physical activity, because we really want to maintain or achieve a healthy body weight, because obesity does put us at a higher risk for all of the other risk factors. We're talking a diet rich in fruits and vegetables, focusing on whole grain, high fiber foods, fatty fish with your omega-3s at least twice a week. And then on the other side, limiting the intake of saturated fats and trans fats by picking leaner protein options, really minimizing the intake of processed beverages and foods with added sugars, being mindful with our sodium intake for blood pressure issues, and of course, consuming alcohol in moderation. So after all of that information, what are some practical nutrition tips that you can put into practice? So tip #1 that I have for you is to focus on heart-healthy carbohydrates. There are essentially 3 types of carbohydrates out there: starches, fibers, and sort of refined sugars. Some carbohydrates occur naturally in starchy foods, such as your traditional starches, so rice, corn, potatoes, and even fruit. Refined carbohydrates or the simple sugars are often foods that have all of this simple glucose molecules, and these raise your triglyceride levels that are closely associated with increasing the risk of heart disease. Now, what we want you to focus on is fiber. So that is going to be the main kind of player in this game. We really want you to shoot for at least 20 to 25 grams of total dietary fiber a day. We don't really have to worry about soluble versus insoluble fiber. I know a lot of patients mentioned that to me. Soluble fiber is essentially a gel-like substance that kind of works like a rake in your blood vessels, and it kind of scrapes cholesterol out. And insoluble fiber works to bulk your stool. We don't really have to worry about the breakdown of this as long as you focus on the total dietary fiber of your food products. So I would recommend trying to shoot for lots of whole grains. The American Heart Association recommends that half of your grains in a day are whole grains. So trying to choose whole wheat bread and brown rice and whole grain pasta over the white processed products more often than not is helpful. Shooting for your fruit servings in a day, prioritizing whole fruit over the processed items. And so I would rather you have a whole apple over apple juice, apple sauce, apple jelly, and of course, meeting your vegetable servings in the day as well. And on the other hand, we got to limit the refined carbohydrates. So processed products such as table sugar, sweets, pastries, cakes, cookies, all the fun foods should be limited. Not that we can't have it at all, but really kept to a minimum. Tip number 2 is going to be focusing on the types of fats that's coming in your diet. And so saturated fats are the fats that are often found in animal-based products. And this is the biggest contributor to raising the low-density lipoprotein cholesterol, or the bad cholesterol, as Jacob walked through with us. And we really want to swap out these foods most of the time for leaner options. And so, for example, a high fatty steak, swapping that out for a leaner cut of meat most of the time would be a better option. We also want to avoid trans fats, as it really increases the levels of LDL cholesterol as well. This can be found in processed foods such as stick margarine, shortening, processed sweets, baked goods, some fried foods, and packaged foods. We want to encourage you to pay attention to the nutrition label. And so avoid foods with partially hydrogenated oils in the ingredient list, because it is often the main source of trans fats in these products. Here are some swaps that you can try to kind of reduce saturated fats in your diet. And so on the left, we have full fat products, full fat dairy products such as whole milk, cheese, yogurt. So switching to a 1% or a skim milk and picking low-fat cheeses and non-fat yogurts most of the time would help. Instead of, again, a A5 Wagyu steak, picking a 90% lean ground beef most of the time, and leaner cuts of all these red meats would be a better choice. Even with something like poultry, the chicken skin and fat, that is usually where most of it is. So removing the fat and making sure you're not deep frying all of your poultry would help. And then for things like butter, stick margarine, cream cheese, using a reduced fat or a plant-based butter or a whipped cream cheese often really lowers the amount of fat you're having because you're eating a smaller volume overall. And on the left, we see coconut oil and palm oil. So these two oils are sources of saturated fats. And so these are often cooking oils or sometimes utilized in marinades and things like that, and certain cultures utilize these oils. We really want to encourage you to switch to a vegetable oil blend that is a little bit more unsaturated. So after all of that, how do we sort of make the move towards a Mediterranean diet? First step is to sweep your pantry and identify the high processed foods so that we know where they are, and we're going to try to reach for these options a little less often. We really want to prioritize lean proteins. Again, your fish, your seafood, eggs, low-fat dairy, beans, legumes. We want to enjoy fatty fish like your salmon, mackerel, cod 2 times a week, because these fish are good sources of those omega-3s that Jacob mentioned, which are heart-healthy fats. We want to limit the red meats, and so we're lowering saturated fat overall to 1 to 2 times a month. And then again, really emphasizing fiber, picking high fiber options all the time through whole grains, your fruits, your vegetables. And then with flavoring food, really prioritizing herbs and spices over high sodium seasonings like obey and marinades that come with a lot of added sugars. And of course, using oils and fats in moderation, really making sure that the oils and fats that you have on an everyday basis are more heart-healthy, unsaturated fats like the vegetable oil blends versus the saturated fat blends like coconut oil and palm oil. As I wrap up, this is a sample one-day menu of the Mediterranean diet. It tends to be a little bit more plant-based, but if you remember how that pyramid looked, they really encourage animal products and that moderate to low intake level. And so for breakfast, of course, we have an omelet with some veggies, some coffee, and some good carbohydrates through fruit. For lunch, again, really focusing on whole grains, high fiber options, fresh vegetables, beans, legumes. For dinner, we have grilled salmon, which is a great fatty fish. We have, again, high fiber, whole grain pasta, some veggies, and then some grapes. And for snacks, lean proteins, low fat dairies with high fiber berries, unsalted nuts as a good unsaturated fat, or you could do hummus, which is made out of chickpeas, again, another bean and some crunchy vegetables. So this would be a sample of what this would look like. Make sure that whatever it is you're picking to do, it's something that you enjoy and works for you. So it doesn't necessarily have to look this way. This is just an example of all of those different elements that we talked about coming together.
So I will say that, and thank you both. I think that was very informative. So a couple of things I just wanted to kind of ask and or clarify. So Jacob, the importance from the PCP's perspective, right, is that we are going to have the patient come in and get their physical every year, right, so that they can get their lab work done and be more preventative, correct?
Yes, absolutely. The recommendations for men is to start screening around 35. Women, it can go as high as 45, but typically most people have at least one or two risk factors that warrant starting sooner. And so most of the time we have younger people in their 20s, 30s, 40s who aren't really thinking about coming in so often, but as long as they can come in once a year for the physical, that gives us an opportunity to order a screening panel of blood work just so we can make sure that everything is up to par. Because of course, our regular patients that we see who are on medications and whatnot, we see them pretty regularly. We'll check blood work more often. But the key here, as far as preventative, is finding these things out sooner rather than later, so that way we can give them this information quicker and, you know, making sure they know that this applies to them and what they can do to really reduce their risk going forward.
Thank you. I think, those are the kinds of things that we like to make sure everybody kind of comes away with from those things. And then in your history, you're going to look at what their family history is and those kind of things, because I think without us asking those questions of a patient, they may not be thinking about, they're like, oh, I'm young, or I'm healthy, I feel good, so they're not worried about like the family history, as you mentioned earlier.
Yeah, exactly.
And Ern, so one of the things I just wanted to mention about the Mediterranean diet is really this can become a way of life versus I think, a lot of people kind of have that stigma, right, around the word diet. And so when we look at it as being a more healthy way of eating, I think it kind of makes it a little easier for everyone to think about versus I'm on a diet, because I think sometimes we do believe that then we're limited on things, and when we're limited, then we kind of want them more, right, than if we try to look at this. And it doesn't mean that we're never going to have things in that upper pyramid, right, like the sweets or things like that, but again, looking at it as being more minimal. Correct, and not on a daily basis.
Absolutely. Yeah.
All right. Do you guys have any questions or any last minute comments? All right. Well, I want to thank you both. I think this was very informative for our patients. And so again, if our patients have any questions, please feel free to reach out to our dietitian department or out to your primary care physician. Thank you both for joining us today. And we will be back next month. And Ern, you're going to be presenting again, correct?
Yes.
In April with another one of our primary care specialists. And what is our topic for next month?
I believe it's brain health.
Yes. Okay, thank you. So stay tuned, and we look forward to having everyone back next month. Thank you all.